Good morning, good afternoon, depending on where you are in the world, and welcome to another IPC Partners Journal Club. I'm delighted today to welcome Brenna and Sara here today to talk about burnout and this hidden epidemic around infection prevention practitioners. They're going to be talking about a study that they were both involved in, which was published very recently in the American Journal of Infection Control. And we're going to have a slightly different take on things today from IPC Partners Journal Club. And we're just going to have a chat. We're going to talk about the paper in detail, and you can have all four of us, and we're going to, take Q&A at the end as we normally do. But yeah, John and I are both really excited to talk about a topic which is, something that I've talked about with colleagues recently, and something that I think that is very important, within healthcare and within infection prevention control. So before we get into the discussion, we'd just like to remind you all, if you're a newcomer to the IPC Partners Journal Club, and depending on where you are in the world, we have some kind of things that we always try and create within our journal club. So we always try to focus on a topical IPC published paper, and this is the one that we're going to run through today, talking about burnout. But ultimately, it's all about trying to generate some discussion. So we'd love you guys to use the Q&A box that's at the top of your teams to be able to ask questions to the authors, and for Brenna and Sara here as well to talk about maybe their insight and how they developed the study, or questions that you might have about, how you can learn from this work and put it into place in your own organisation. We wanted to be able to provide some opportunity for development as well and exercise critical thinking. And we'd love you guys to be able to take what we do here and build it into your own independent research and study as well. We'd like to think that we're building a bit of a network of enthusiasts as well. And as well, we don't take ourselves too seriously, so we'd like to have a little bit of fun. We record all of our journal clubs. You're all muted and your cameras are off. But all of our events are recorded and will be on our YouTube channel. So without further ado, it's my pleasure to welcome Brenna and Sara. So to kick off, John and I thought we would just talk a little bit more about maybe our own personal experiences of burnout. So let's go to the guests first. Brenna, anything you'd like to share in terms of, burnout and your experience of it?
I'm having some trouble with my mic. Sorry, there you go. My mic was being a little recalcitrant. Yeah, I think we've all, as healthcare providers have, experienced COVID, and COVID, I think, was the time that really resonated with us deeply. And, working in that space, I was in Los Angeles during the beginning of COVID, and, it was really challenging, a lot of patients. And being in the front lines with the nurses and doctors taking care of COVID patients, just really watching people give everything they had to the patients, trying to provide care, trying to help keep people comfortable as much as they could. It really resonated with me, and was really the first time I experienced burnout, I think a little bit personally, but more in a community of people where they were giving everything they had, and watching them burn out in front of my eyes. And I think what drove home for me was one particular instance or situation that I recall where I asked them a question and they started crying. And I don't know if it was me or the question or just one more ask, but this person just started sobbing right in front of me. And I felt so helpless and so powerless and so upset with myself, what did I do? How did I cause this? And I held her and I hugged her and she cried. And she's just like, I can't do this anymore. And I just held that space with her. It really had me thinking about, again, not only burnout from a personal perspective, but really how does burnout affect all of the people that are working in a healthcare space, and how can we learn more about that, and how can we better support each other, because we are not alone.
Yeah, thank you for sharing that. It's kind of a really powerful insight, and I think we're really keen to understand the lessons that you've learned from the work that you've done. So thanks for sharing that. Sara, what about you?
Yeah, so during COVID, I was a frontline IP manager at a major healthcare system just outside of Denver, and it was a rough year. The system itself was difficult to work in at baseline, and then throw COVID into it, the expectations and the fear and the anxiety and just kind of keeping it all afloat as a manager of that program was insanely hard. And but towards the end of 2020, I was struggling, but I wasn't willing to admit it to myself. I was like, I could keep doing this. I've got this. And then my 9-year-old boy at the time, I had mentioned to him at some point that there was a job I was interested in applying for, and he's like, "Did you apply for that job?" But Mom, you really need a change. I'm like, "Oh my God, my 9-year-old is seeing how bad this is on me, but I'm not willing to admit it." So I ended up applying for a different job. It was still within infection prevention, but it was actually it was a promotion, which was great. But it was a system director job in a different system, and but then I got tossed into the role of leading IPs that were on the edge of burnout and how to pull them back and bring them in and make them a family and bring them back to the point of, patient care and team is what's important here. And so I got to see it kind of from both eyes, but I really needed that change in perspective to bring me to a better place personally and for my family. So yeah, this topic is very near and dear to my heart as going through it throughout COVID and kind of the post-COVID aspect with the field of infection prevention.
Yeah, thank you for sharing. That's a really powerful story, and really kind of inspiring, the work that you've gone on and done, both from kind of recognizing that in your own personal experience and then helping others as well. And I think, the COVID pandemic will resonate a lot with the people on the call. It was a tremendous element of, stress, anxiety, worry, fear, all those emotions that we all got mixed up in and experienced. John, what about you?
Yeah, hi everyone. It's difficult to sort of explain to somebody the pressure cooker that COVID was for a frontline infection prevention practitioner. It was just everybody wanted everything from you all at once, and it was just a series of impossible scenarios. So I can see how that prompted burnout pretty quickly in people. I am grateful that I've not been through it myself, but I have had people very close to me who have exhibited a classical burnout, and it's a bit like watching a child grow, in that day by day you don't really notice, but if you take stock or an acute event happens in a relationship and you just suddenly think, you're not right, this has been part of an ongoing program, we need to do something here. So I'm really interested to talk about the study and the way that it was measured, and then hopefully we can get on to what we love best, which is prevention, not so much of infection but of burnout.
Mm-hmm. Definitely. And I'll just share really quickly my own kind of personal experience. I think working within the healthcare setting during COVID, there was a lot of challenges, and I think that it was only post COVID when people started to realize just how much strain and pressure that they'd been through. But I think really trying to reflect really personally on my own career, I think there was a time last year when I was working in acute trust, and we were just overwhelmed with flu. And flu, was causing so many challenges for the organization around operational capacity and flow and infection and transmission. And every day, just felt like you were really, really close to the edge. And you could see it in the team around you as well. You kind of been challenged with different decisions and difficult decisions all the time. And I think a lot, sometimes it maybe highlighted and brought back up some of those challenges that we did experience during COVID, not to the same effect and severity, but definitely kind of some of the challenges that we experienced in COVID. So let's delve into the study. Sara, perhaps you want to, or Brenna, perhaps you want to just kick us off a little bit of an overview of what you did and how you did it, and we'll let you take the floor and summarize it for us.
Yeah, sure. So the motivation behind doing this study, Brenna and I were working on a project together at APIC on IP retention and attrition. We really wanted to understand the drivers of why IPs were staying in the field or why they were leaving. And then we did a whole bunch of focus groups in the beginning of that study and really trying to delve into the topic, and burnout just kept coming up. It was, COVID just really, as we just talked about, really bothered and impacted a lot of IPs in the field. And so Brenna had been talking about utilizing the MBI, the Maslach Burnout Inventory, and seeing if we can really understand what is kind of the driver, obviously not the major driver of burnout, but really where are IPs at and how can we help them and hopefully maybe prevent burnout. So we dove into that, and we wanted to pilot it because the tool, while it's really awesome, it's not cheap, and so we wanted to make sure it was actually impactful for IPs to use. And so we decided to pilot it on 2 chapters in the APIC. And so we did the San Francisco chapter and then the Delaware Valley, Philadelphia chapter, which was cool because it was like two polar opposites on the country. And so you have a lot of different pressures that are impacting IPs and different IP populations that make up that group, those two chapters. So we brought those groups in and we were able to do a pre-survey. So we really wanted to see where the IPs were at baseline, and then we gave them the assessment, and then we did a post-survey. And so it was fun to compare the different chapters and how the demographics of the different chapters and how they were made up, and then looking at the results of the survey itself. And so within that, we found out shockingly that IPs are on the edge of burnout. There were a lot of different variables, and I'll let Brenna kind of dive into the details on really what dictated the definition of burnout with depersonalization and feeling ineffective and the measures of the MBI. But ultimately, we did find that, IPs are struggling, which we knew, but we actually had the data to prove it, which was really cool because there hasn't been a lot of information, especially post-COVID, that's come out about how the IP field is feeling about burnout and where they're at. And so ultimately, our conclusions came around to the point of, our organizations need to recognize this, they need to understand it, and they need to be sympathetic to it, and they also need to prevent it. And we offer suggestions on how organizations can do that, but it also can't just fall in the organization. It has to fall in the IP as well to make, to understand, have that self-assessment of, which is something I obviously failed at doing personally, of being able to look at themselves and be like, I am struggling, I need help, like I need change, I need something, and really to be able to have that self-assessment, if you're not getting it from your organization or your leader. So it was a really fun study to do. I mean, obviously not the most uplifting topic, but I think it was just fun to be able to, find the answers that we knew were out there and to be able to prove the point that we're trying to make.
That's a really good overview. Thanks for sharing that. I'd love just to go into a little bit more detail about the methodology that you guys used, because I have to admit, it's something I hadn't heard of previously, and I wrote a blog on the paper and I had to go and research the method. So tell us a little bit more about the methodology, how it works, and kind of how you implemented it.
Yeah, I'm happy to take that one. So there's been, some great studies that have, looked at burnout, asked IPs, are you feeling burnout? What's your level of burnout? The challenge with prior studies, most have written about the COVID pandemic, is that they weren't, kind of a gold standard assessment. So yes, we knew based on the literature that IEPs were feeling burnout. They were self-identifying as burnout, but did it meet actual definition for burnout? And the intention behind using the MBI was twofold. One, we really wanted to understand how IPs were experiencing burnout, and we also wanted to use an assessment that is considered the gold standard of the burnout kind of inventory assessment process, that we could then measure IP burnout with other healthcare providers, kind of looking at it from an apple to oranges perspective. So that was kind of the thought process, the intention around using the MBI. We wanted to do a pilot because this is the first time the MBI has been used for infection preventionists. And so we wanted to kind of create, a couple, smaller group, just kind of get a sense, not only how did the assessment rate infection preventionists, but did that assessment really resonate with IPs? And so that was something we wanted to look at, again, from both ends. And so to Sara's point, we looked at two different chapters from two different sides of the country. And part of the reason for that is, California, so San Francisco is the state of California. California is known to have kind of more regulatory requirements. We have kind of additional things that we report, additional considerations that not all other hospitals across the country have. Same thing with the Philadelphia chapter. They also have some regulatory requirements and reporting pieces that are not necessarily, work across the country. So it gave us kind of an opportunity to see, again, two different groups of people, two different sides of the country. What does that look like? And what we found was, to what Sara was sharing, is there was a lot of exhaustion. IPs were tired. But something else we kind of noticed is that the MBI assessment really talked about providing direct patient care. And so whereas this MBI assessment is specifically created and designed for medical workers, this particular MBI asked about, how do you feel depersonalized when you're caring for patients? And so again, we had this piece where, IEPs don't directly provide patient care. And so we were able to kind of, talk to the group, how do we want to answer this? And so we had IP just look at it through the lens, like, while we're supporting patients, do I feel depersonalized? And what we found, kind of overall, is that there was this state of exhaustion, but IP still felt really passionate about their work. So they still felt very engaged to it, very connected to it. So regardless of what their workload was or what challenges they were facing, they still very much had that passion for the role. And I think that's something that, Sara and I have learned through this process, comes about with this idea of resiliency. So one of the, I think, most interesting pieces here is you can be exhausted, you can, not have a great day at work, you can even, maybe have some challenges around boundaries. But as long as you maintain the passion, the daily passion for the work that you do, you still feel like you have purpose and you're making a difference. That is the resilient piece that helps prevent burnout. And what we found between the two chapters is nobody in the Philadelphia, Delaware chapter identified as burnt out, but we did have a few people in the San Francisco side. And so, again, we don't know who those people were. It was all done anonymously. But we've kind of thought about, okay, well, what's going on in San Francisco? Whether it be, the regulatory environment, the reporting environment, the hospital culture, that might be leading more IPs to feel burnt out. So I think that there's, a lot more exploration that needs to happen. But in talking to our colleagues as a whole, what we have found is whereas IPs may identify with this concept of burnt out, again, as long as they're feeling that they have purpose, that they have value in the organization, that their work matters, they maintain that passion. That seems to be that resilient piece that helps prevent burnout. And I'm happy to expand on any of those points. I know it's kind of a lot.
Yeah, thanks, Brenna. Really interesting. And I think I can probably spot somebody who's burnt out, but how do you measure it objectively for the purposes of a study? What's the definition of burnout?
Great question. Sara, would you like to take this one?
I mean, I think it comes down to the science behind the assessment, the MBI assessment. I think it, they look at the types of questions they ask are just that, I don't remember. I didn't take the assessment personally because I wasn't an IP in the field at the time, but just looking at how people are feeling in certain situations, and then they have their special science behind it where they calculate the burnout aspect of it and give you numbers to it, which we were not privy to, just understanding the report out of the assessment itself. But one other thing I did want to add on what Brenna said is that, none of the IPs felt disengaged. And I also found that when I was talking to IPs that have left the field, when I was doing focus groups, they all love the field of infection prevention. The passion never waned. It was always just all the external forces that were coming in that were driving IPs to leave because they just couldn't deal with the other stuff, we'll call it.
Thanks. Yeah, I think John made a really good point there about burnout and something all experienced or come close to, but it's really key to kind of define that definition of it. And I think what you've talked about really helps shine a light on that. So going back to the paper and the study, and you've alluded to kind of some of the differences between the two chapters. Were there any common themes, between the two chapters that you were able to distinguish, something that came out regardless of where you were geographically?
Yeah, everyone was exhausted. That was pretty universal. Really, they felt overwhelmed with the workload. They felt overwhelmed with barriers in navigating their daily work. They also, when we did the pre-survey, the assessment and the post-survey, there was not a long duration of time. It might have been a week to maybe 3 weeks in between the pre-assessment, the assessment, and the post-assessment. But what we also found kind of interesting is most of the participants that took the post-survey, again, 1 to maybe 3 weeks after they took the assessment, said they felt better. So I think there's something about thinking you're burnt out, right? Taking an assessment that really helps define, am I actually burnt out? And again, for most of the participants that took the study, they did not meet this definition of burnt out. And so I think there's this alleviation, like, okay, yes, I'm exhausted. Okay, yes, it's a lot, but okay, I'm not burnt out. So I think there was kind of this relief. And I also suspect for people who did identify as burnout, it was validating. So yes, I'm feeling these things. Yes, it's nice to see an assessment that is really, defining how I feel, and now I can describe it. I can touch it. I can feel it. That's what this is. So I get the sense that that was maybe the primary piece behind why people felt better after taking the assessment. And again, I think knowledge is power. And one thing I love to say about IPs is we're highly inquisitive, highly curious. I don't know an assessment we don't like to take for fun. So I think, again, taking an assessment, really answering those questions truthfully, honestly, and getting a sense of where you're at from an IP perspective and a human perspective is highly empowering.
Yeah, and I think I think also just the awareness and understanding more about what burnout is, as well as what these other terms, the depersonalization and this disengagement, what that means. And then also what was really cool about the report is that when we signed up for it, we allowed them to get an individual report on their responses. So they got a lot of information about how they responded. What does it mean? What can you do to prevent to get to burnout? So I think that was key in the kind of the benefits of this, and looking at how IPs felt better when they took the post survey, because they knew more. They knew what to look for, knew what to, what to expect if they're getting close, or what tools they could use to prevent it and moving forward. So I think that was another key point that was kind of a benefit of this project, and the tools that the MBI provided post assessment.
So there's almost a bit of a parallel with the placebo effect here, isn't there? In that there was no specific therapy or intervention, but just the very process of almost the study taking an interest in the person made them feel a little better. Or perhaps it's not that at all. Perhaps it's more that the assessment almost all of the time said, actually, by this objective standard, you don't meet the criteria for being burnt out. Therefore, there's people doing a lot worse than me in the world, and that can be a sort of selfish but quite comforting thought sometimes. So yeah, I'm interested in your thoughts.
Yeah, I would love to say that I feel like this concept of burnt out, when it was related to COVID specifically, there was a lot of compassion for it. We all of us who were in the hospital, supporting the frontline people, we all felt it. What I think is kind of unique about our study is we didn't do this in COVID. We, collected this in the fall of 2024. So we're now, a few years out of COVID. And the reality is that the work environment's still hard. Our day-to-day job is still hard. We're still being asked, to do impossible things. We're still being taxed and asked to operate in ways that are just beyond our capabilities sometimes. We're short-staffed. We work long hours. The demands are kind of never-ending. And so I think one of the reasons why Sara and I wanted to do this at this time is we wanted to know, is our IPs burnt out in general? Is it really our current work environment, following up on that study that she primarily led? Or is this residual from COVID? Is it this or that? And so I think another piece is, again, people who are feeling burnt out in 2024, whether they work through COVID or not, again, there's some shame there. Burnout, like someone says they're burnt out, you're like, oh, you're, burnout, oh, right? There's kind of this negative connotation associated with it. So I think there's some shame and some guilt. I feel burnt out, or I feel depersonalized, or I'm not feeling engaged with my job. Again, I think that there can be some shame there. And then talking to people, after the survey, around the survey, I've had people reach out to me. And, one of the thing I've heard most that's resonated with people is I loved hearing that I'm not alone, that I'm not uniquely experiencing this, that this is something other IPs are experiencing. Because again, IPs don't provide direct patient care. And yes, there's research and conversations for nurses and doctors, as there should, right? They are frontline, they're hands-on patients. But how does burnout affect kind of the ancillary support services like us? So again, I think there's just been a lot of shame and guilt and kind of the secret a little bit about this feeling or experiencing burnout. And one of the things I was hoping by achieving with this study is to demystify it a little bit, to let people know that this is something on a human level we experience. You are not alone, and really kind of help start the conversation about what burnout is for IPs, and then how do we move forward? To your point, how do we start getting towards the space of prevention?
And I think also, like, COVID was kind of a catch-22 for IPs, because we were put in the limelight. We were shown what we can do and how awesome we are in a hospital setting, in an environment that's stressful. And we also know our field has changed tremendously over the last 10 years, and the expectations of the field. COVID was just one part of it. But I mean, you think about all the regulations that are increasing, at least in the United States, all the requirements of this role and expectations of this role. And then to show how great we did in COVID, it just kept piling on without the additional staff. So I think it's just, hey, they can look at all the stuff they can do. We can get them more. And so I think it's just led an evolution of the field. And so COVID itself was rough, but then the expectations have piled on without the additional staff, without the additional support. And now we have IPs in a state where they're like, I can't do this. This role's not fun anymore, which is sad because it's a fun role.
Yeah, and if I can, I'd like to piggyback on that. And again, I can only speak, for the US, Los Angeles, but I remember when COVID started, and I think there's probably a lot of IPs that can resonate with this. We got free lunches. Like, people were like giving out discounts, like, it was really cool. Like, yes, frontline workers, yes, you guys are helping us. But by the end, COVID, the attitude towards us was 180-degree difference. I mean, I remember a physician that I really respected accusing me of hiding sanitizer underneath my desk because we were, everyone was out of sanitizer, that we were hoarding it. And again, it's so unlike this person, right? But this was just the times that we were living in. And so I think another reality of this is, again, we experienced this on a human level, but after COVID, that attitude changes. The funds, we had a lot of federal funds that helped support hospitals during the time. Those funds, got rescinded because COVID was over. And now hospitals were navigating this new financial environment where they didn't have the funding that they did. And then they had to start making cuts. And so where does that come from? And understandably, I don't love it, but I understand it. We're not cost revenue. We're not revenue producing, right? We cost money. And so sometimes our departments are the departments that make sense to slim down, whether it be through layoffs or letting go of positions through attrition. And so to Sara's point, not only did we experience this 180-degree attitude change towards us as a profession, we also experienced that from our leadership. When there was a CDC change, we were talking to our C-suite every day. Okay, what do we need to do? How do we move patients? What's needed? After COVID was over, understandably, right, nobody wanted to see a respiratory mask or an IP. Like, everyone was just over us, which again, I appreciate. So it also just affected how we were treated by our peers. And then we've been navigating just, kind of a myriad of financial challenges that have really impacted our funding for our departments and our ability to function with added responsibilities, more diversified responsibilities that require, a lot of time and coordination and multitasking from IPs.
Thanks, both. I feel like I've got so many things to talk about in that discussion there. I mean, firstly, the ability to kind of validate those feelings that people might have had and generate an avenue for discussion. And it's really interesting, actually, that some people are sharing their own personal perceptions in the chat here. And I think it's just a really great forum to be able to talk about this and not make burnout taboo. I think that, it's really interesting as well what you were saying about that expectation post-COVID and how more and more has kind of been piled onto IPC. I think from a UK perspective, there's been this kind of maybe merging of IPC and occupational health, because there was this, area around IPC advising on personal protective equipment, around masks and gowns, and then, potentially vaccination as well. So I think that there's responsibility added there. So I think there's a lot that we've experienced similar from a UK perspective as well, that IPC really was at the forefront with COVID and did such a fantastic job in navigating such a constantly evolving and challenging threat. But then that kind of just carried on and that expectation stayed there. And I think, again, UK perspective, that some of that resource has eroded away. I think that you talked about that, Brenna. So I think we'll have one more question from me and then we'll open up to the Q&A. So people who are on the call, please do use the Q&A for questions for our guests. I'd like to talk a little bit about what that means for the organizations that we work in. I think if I was a chief executive or a leader and this work was published in one of my organizations, it would sound alarm bells ringing. I understand that we're funded differently from a UK and a US perspective, but what do you think the kind of key organizational learnings are from your work? And is there anything you think you can share with the audience about how organizations can prevent or mitigate burnout within their employees?
I mean, I think ultimately when partnering with HR, the HR departments, because HR, at least in the US, is a huge influencer on how employees are supported. And I think being aware that this is a challenge for not IP is obviously super important, but all healthcare, really, we're all struggling. And I think it just shows the importance of being aware of it. So I think partnering with human resources and trying to figure out what are ways that we can prevent this. Do we want to assess our employees? And if so, then we can learn more. But if they're not willing to at least go down that route, but just understanding what tools and resources are out there for their staff and offering it. Every organization I've worked for has been very different on what they offer for work-life balance and what they offer for, support for their employees, the employee assistance offerings. And so I think just being open to those ideas and being willing to support it, because replacing IPs is a really difficult thing to do. And you don't want to lose your IP for many reasons, at least most IPs, because we're all pretty awesome. And so just trying to make sure that you have the resources available to keep them. And then I think even as an organization, tapping into those leaders of IPs, checking in with your IPs, making sure that they have those work-life balance parameters set up, that they're not working themselves to death. I think the leader has to play a role in this too, and having that personal touch with their infection preventionist and understanding what burnout looks like. We have IP leaders, IPs that are leaders of IPs in the US, and just they understand it and can be empathetic of it. And I think just when you have a quality leader or an HR leader that's over that IP program, that connection might not be as relevant. So I think especially for those non-IP leaders, really understanding, what burnout's going to look like and being sure you can support your IP in these really challenging times.
Yeah, definitely. I agree with all of that. And I think that one of the strengths of this work that you've done here is it just creates that awareness of the methods that are available to assess it as well. I think, that we've talked previously about that definition of burnout. And I think the methodology and like the study you've got here really kind of highlights that. John.
Yeah, I just want to pick up on a couple of the comments and questions that have come in. So thank you to those listening who've been so candid with their own stories of burnout. Interesting to see lots of ideas about causal relationships between factors in the workplace and burnout. So many people talking about high workload, poor staffing, a sense of others not understanding your work and your workload seems to be coming through strongly, particularly during that COVID period. And I completely relate to that. Whenever I said COVID was really hard for me working in a hospital, like, well, you weren't even seeing patients, you were just giving advice. How can that be hard? People not understanding that, like I said earlier, the pressure cooker you're in. So the question really for you based on the study is, what were there drivers or causal associations identified with burnout, and was your methodology able to give us some clues on that?
Yeah, I would love to piggyback. I love to, share that, and then also just piggyback on something Sara said. So, again, depersonalization and disengagement, I think were probably, two of the biggest pieces. I think exhaustion and IP is almost a given. But when people were no longer engaged in the work again, they lost the spark or they felt like their work didn't matter. Those seem to be two of the biggest pieces from an IP perspective that really predicted high levels of burnout. So what does that mean? That means from an organizational perspective, your IPs, we are subject matter experts. We want to provide advice. We want to work with you to find a solution. We look at our jobs as we, looking at best practices, looking at reality, right? Our job is to work with you to merge those, to marry those two things to find a way forward. And I think sometimes that there's a hesitancy to bring IPs back to the table or invite IPs to the table from leadership because they're, afraid we're going to ask for something more, or we're going to say something that doesn't align with their direction. And I think that can be okay. It can be okay for an IP to be there and to say, okay, this is what I recommend, and for leadership to say thank you for that recommendation. We're still going to go in this direction. I think IPs understand that. So I think from an organizational perspective, listening to IPs, giving them an opportunity to share the recommendations, and then if you choose not to follow them, sharing with them why. I think that part's really important. And then from a personal level, there does need to be some work-life boundaries. And I, did experience burnout, and I was incredibly guilty of this. And I was in a space where I didn't sleep really well. So I'd answer emails 2, 3 o'clock in the morning. And sometimes I'd answer emails at 5 o'clock in the morning. In my head, if I could answer all the emails, like that was a win, right? But I mean, taking a step back, how insane is it, right, to be answering or reading emails in the middle of the night? Like that's insane. But at the time, like that was something I could control. This is something I could do. And then also, like I really focused on, A, B, and C, thinking that that's where the priorities were, but I was completely missing what the priorities really were, which was, X, Y, and Z. So I think another piece of this is just, again, this awareness. You need to be able to kind of see yourself and be able to see yourself and how other people are experiencing you. And when you're burnt out, sometimes you are completely aware about how other people are experiencing you in your world. And unfortunately, people remember how you make them feel. And that's something that I think really resonated with me. And I do some professional coaching as part of, kind of my side business. And I work with a lot of IP leaders, really trying to help them navigate, again, the sense of like holistic well-being, work-life balance. And there needs to be internal, individual level piece on, okay, like what do I need to do to center and balance myself? That I really hope that people can lean into and that we can help support them through.
Okay, thanks, Brenna. So let's see. There may be people listening. There may be people who've tuned in simply because they're feeling on the edge of burnout, or they have colleagues who are burnt out or on the edge of burnout. What advice do you have for them based on this study? What are the kind of practical things we can do to identify it in ourselves and in others, and begin to turn the corner and come back to yourself and come back to the workplace?
I think one of the most fun things that I got to instill upon the new team I took over when I left my organization 2020, went to the new one in 2021, was that sounds like a tomorrow problem, or that sounds like definitely a Monday problem. Like, I think really, I mean, infection prevention, majority of our challenges are not emergencies, COVID excluded. Everything was an emergency in COVID, but, or water falling in from your OR. Those are going to be your emergencies. But typically, while we're extremely important, it's just remembering, like, keeping it the priority straight, and really like, okay, what do I actually have to get done today before I leave, and making sure that list is very short. And then what can I deal with tomorrow? And I think the tomorrow problem in my mind is that was a lifesaver for me, as well as I think for my team that was working with me. It was just, we don't need to deal with this today. We don't need to get worried about it today. It's going to be here tomorrow, and nothing bad is going to happen if we wait. And so that was just kind of like a quick, fun, easy one. I'm sure there's a lot of other great answers to this question, but that was my solution to a lot of overstressed ITs at the time.
I love that, Sarah, because I literally say that every day. That's a tomorrow problem. And I think there's a lot of value in that. I think as ITs, we want to be of value, we want to help. Again, we're highly passionate, highly committed, and we're willing to stay late to help solve a problem. So I think the other side of that is having some realistic boundaries. And again, something that came up for me is the reality is an IT has enough work where they never need to go home, they never need to sleep, they never need to use the bathroom, they never need to eat. So there's always going to be more work. So working an extra 30 minutes, an extra hour isn't going to make the work go away. It's just taking an hour away from your family and all the other things you need to do. And so I would encourage IPs to really look at the workload and say, okay, what, to Sarah's point, what really needs to happen today? Or what needs to happen within these timeframes? And have honest conversations with your leaders. I completely respect that they are expecting more of us, and we do our best to show up. But by showing up and being our awesome selves, we're also demonstrating that we can handle that load. And so when they put on more, well, they know we can handle it. So I think there's also an opportunity, again, for us to really think about putting some hard stops around our time. And the other piece, I think, is self-awareness, really being aware of yourself. What do I need as a person? Did I eat today? Did I use the restroom? Did I spend 6 hours at my desk when you go around? How am I getting my social interactions? I think, again, how am I taking care of myself, my basic human needs is really important in creating awareness. And also, how are people receiving me? Are people feeling stressed? Am I being hurt? My words not, leaving my mouth the way that I intend. So I think there's, a couple different things right there that really help people say, okay, like, where am I at? How am I doing? The quick check-in, and then what do I need to shift or pivot to get where I need to go? And there's no shame in this. As humans, if you're sick, right, you take care of yourself. Maybe you're on the couch for a couple of days. You take your Dayquil, you've got your tissues. So when other things happen, we're on board with supporting and taking care of ourselves. It feels like sometimes with burnout, people feel so much shame about it that they want to will themselves through it, and they really don't take the time to care for themselves the way that they need to.
I really like what you just said about, another hour that you spend doing the job takes that hour away from, your self-care or spending time with your family, but it doesn't necessarily fix the problem. And I think, we're innately programmed when we work in IPC or within healthcare to try and fix it. But actually, we need to maybe take a step back and think of it as part of the longer problem. So I think maybe final question before we close. Obviously, this study's done in the US. John and I are just interested to understand, if you think this would be replicated in other countries, and any insight you might have from working with other people in the field about, is this something that we're experiencing globally? Is it a US and a UK phenomenon? What are your thoughts there about what this might look like if you've done the study somewhere else?
Sarah, you want to take this one?
I'm very self-centered in my US setting, so it's really difficult for me to understand. Like we've been working with Shanae over in Ireland, and she's talking about IPC out there, and it blows my mind the differences. And so I don't know if I could speak well to how this could translate. I think ultimately the field itself across the world is challenging, and I think the baseline items of the expectations are going to be the same. And so therefore the IP should, be able to meet those challenges of the work-life balance and being able to take care of yourself before you, kill yourself in a job are going to be the same. So I think that overall we can definitely translate this into an international study for sure. And I think we'll probably find pretty similar results given that the field is challenging. And while the challenges might be different, the expectations and challenges are the same. And I think the message should remain the same across country boundaries for sure. And taking care of yourself and prioritizing yourself over this wonderful job that we all love.
Okay, thanks, Sarah. So Phil said that was the final question, but it's not, because Alexander has given us one completely irresistible question in the chat that I'm just going to have to put to you. Okay, so if you could wave your IPC magic wand and take away one load or burnout stressor, what would it be?
I'm going to go just simple workload. I think if we could actually give someone an 8-hour day, a reasonable 8-hour day, I feel like that would probably be the number one thing that you can do that would allow the IP again to take care of themselves as human and help reduce some of these impossible competing priorities. What are your thoughts?
I think I'm going to go with taking away the expectation that the IP needs to be in the hospital 5 days a week. I think we have shown in the US that the hybrid, I think we definitely need to be in the hospital for sure, but not 5 days a week. The hybrid model is working where an IP can get a work from home day once a week, once every couple weeks. It's enough to give them a breather. They can catch up on all that desk work that they're going to be doing in the office anyways. And so they can do it uninterrupted. And it just has really helped, I think, the mental state of IPs that get that opportunity. When I was looking at retention strategies, the option to work from home and that flexible schedule was like the number one retention strategy. So I think it goes a long way. And I know the US might be a little bit more forward thinking in this, but we still have a lot of resistant organizations that want their IPs in the hospital rounding 5 days a week, but it's just not feasible. And for the mental health of an IP, it just to be able to sit at home, roll out of bed, get all your work done in that 8 hours and go on with your day without that commute, without the interruptions. It's huge.
Okay, well, look, fantastic. Brenna, Sarah, thank you so much for joining us today. Thanks for your candor and your openness. I've thoroughly enjoyed that conversation. The time's really zipped by, and thank you to those who've joined us and for your questions and for your openness as well. I think it's been a really important conversation. I suppose one of the take-home messages really is, if you feel like you're struggling and on the edge of something, talk to someone. There's loads of people around, loads of people have been through it. Let's take away the shame and let's carry on the conversation. I think that's a really important learning point from this conversation and from the study that you've done. There's the age-old analogy of the gas, not the gas mask, the mask on the plane, as in if the cabin depressurizes, you've got to put your own mask on first, because otherwise you're no good to anyone. I think that's true in any workplace, but particularly in a workplace that can be as stressful and emotionally bearing as ours can be. Okay, so looking forward on to the next event. So in a couple of weeks' time, we're delighted to have another transatlantic collaboration. Dr. Alexander Sunderman will be talking to us about genomic surveillance for IPC, principles and practicalities in the next of our Insight webinar series. So Insight webinars are slightly different to journal clubs in that we sort of go in a little bit deeper into the subject area and let Alex lead us through that. So if you want to register for that event, the QR code there will take you through to the registration page. Following that, throughout the course of the year, we've mapped out quite a few journal clubs and Insight webinars. The idea is that you have kind of one of each a month, so every couple of weeks is either a journal club or a webinar. So take a look at the live schedule and you can register for future events there. And finally, as Phil said right at the start, all of our journal clubs and Insight webinars are recorded and posted on the YouTube channel here. So one big final thank you to Brenna and to Sara for joining us today, and we hope to see you all again soon. Thank you very much, and bye for now.